welcome to the Journal of the American Society of Echocardiography podcast. My name's Johri, and it's my pleasure to present this week's episode. I'm very, very excited because I have two luminaries with me today. I have Jennifer Neary, who is a wonderful sonographer that I had the wonderful pleasure to work with when I was at Massachusetts General Hospital. And as you all know, Dr. Jonathan Lindner, who is one of our past ASE presidents. So I'm very delighted by this special podcast today as part of our summer series. And as you know, what we do is introduce the articles to whet your appetite, to encourage you to download the paper, rather than providing a comprehensive view of all aspects of the paper, but just to get you interested in what's happening in the journal this week. And so what we're going to do is first start off by presenting the expert ASE consistent statement on hypersensitivity reactions to ultrasound enhancing agents. That article is in the current July issue of the journal. But as a special treat and related to contrast agents, we're also going to talk about an article that is currently in press. So it's present online, but it may be modified before its final version, and it's included into an issue. That article is called "The Routine Use of Contrast at Admission Echo for Heart Failure Reduces the Rate of Repeat Echo During the Index Admission." So we'll talk about both of those articles today. And I'd like to introduce our guests here today. So firstly, we have Jennifer Neary. Jen, can you say hi?
Hello.
And Dr. Lindner.
Hi there.
Thank you for joining us. So Jennifer, what's going on with you? Where are you at right now? You're a sonographer, and I think some of us know you, and some of us are delighted to see you.
Yep. So I'm currently a sonographer at University of Colorado Hospital, and I'm currently on week 8 of maternity leave, and presently in Massachusetts visiting family on Martha's Vineyard. So got me right in the middle of a pleasant vacation and a little bit of a sunburn.
You're on Martha's Vineyard right now.
Yep.
That's amazing. That's wonderful.
In Vineyard Haven, it's lovely.
Okay.
The weather finally broke.
Don't watch JAWS.
We actually went bridge jumping on the bridge, on the JAWS bridge the other day. So
okay.
no fear of sharks here.
What is the JAWS bridge about?
So the JAWS bridge is like, there's like an iconic shot from the film where the shark is coming through into this like internal bay. And it's a bridge on the road to Oak Bluffs. And there's 2 of them. So the second one is known as the JAWS bridge.
Okay, that's wonderful.
I probably shouldn't have admitted because I think that there's signs posted that say no jumping off of the bridge, but.
Okay. That's great. And we're looking forward to hearing a little bit more about you after your presentation as well. Jonathan, can you tell us what's going on with you and where you're at?
Oh boy. Well, just continuing on with the diverse research activities. My ADHD certainly has not calmed down doing clinical and preclinical studies. I am on the opposite end of the paternity-maternity spectrum as Jennifer, which is my daughter is going to be going off to college in August in Boston. She's going to Brandeis.
Wow.
So
okay.
Anybody around in the Northeast who wants me to come visit, starting in mid August, I'm ready to come.
That's great. So you're looking for invitations for talks and stuff? Is that what you're saying?
Yeah, looking for invitations for an excuse to drop in on my daughter and see how things are going.
That's great. That's wonderful. All right. Well, let's get started with today's program. So Jennifer, I'm going to let you share your screen, and you're going to present some slides from the consensus statement, and then we're going to get Dr. Lindner to chime in as well.
All right. And let's see. Full screen. Can you guys see that? Okay.
Yes, and if you can do the perfect.
So we're going to talk today, as Dr. Johri just mentioned, about the expert consensus statement that just came out. And I think it was this month's issue, right, of JASE. And the paper was published by Dr. Lindner back in May about the hypersensitivity reactions that are, I guess, triggered by polyethylene glycol, otherwise known as PEGs. And I was actually really excited that this came out because, you know, as a sonographer who now administers contrast, at my previous job, it was always a nurse or a physician. And then when I transitioned into, I guess, becoming self-sufficient, I started administering it, and you never had a knowledge of who or why or when patients were going to have these reactions. And they're exceedingly rare, but it's always like a little piece of anxiety hanging out there of, you know, is this patient going to be the one that, you know, develops renal pain or chest pain or shortness of breath or even any sort of anaphylactic reaction. So I think this is a great step towards knowing a little bit more. And I think at the end of the statement here, the recommendation is for further prospective studies where this was a retrospective analysis. So I'm excited for that, and kind of maybe someday we'll know exactly who and why and when should not or has a higher likelihood of having a reaction to Definity or any of the other FDA approved ultrasound enhancing agents. So here's the intro from the paper, that this consensus statement on ultrasound enhancing agents provides practitioners of echo with information and recommendations that will benefit patients. And I just need to adjust this, sorry, where you guys are hanging out on my screen is blocking it. Okay. So again, hopefully to increase the safety of administering this, you know, very helpful agent. So it also provides expert opinion on the clinical impact of this recent MedWatch alert. And that is for hypersensitivity reactions, specifically to polyethylene glycol components of the ultrasound enhancing agents. This is specific to the agents approved by the FDA, sorry, where, and you know, you're killing me with these big words. Perfluorocarbon or sulfur hexafluoride microbubbles stabilized with the shells that are composed of albumin or a lipid. And these lipid-based UEAs include polyethylene glycol as part of the vehicle or microbubble shell. These agents normally interact with the immune cells, an uneventful mechanism for clearance of UEAs from the circulation. So as I'm reading all these big words, and you know, I think a lot of the sonographers reading these journal articles, your brain sometimes shuts off to what it's actually saying. So maybe Dr. Lindner can put it into, I guess, layman's terms a little bit. But as I understand it, these PEGs are what kind of give the shell a little bit more of a robustness. And
yeah, so that's a great point, Jen. Let's get Jonathan to weigh in on the shells, and also I believe he wanted to make a comment on some of the agent types that have this shell versus some that don't. So Jonathan, would you like to chime in at this point before Jennifer moves on?
Yeah, sure. So here's the bottom line. PEG is everywhere. It's you know, it is in so many different drugs. It is in so many different cosmetics. It's in the mRNA of the or mRNA vaccines for COVID. It really is everywhere. And the reason is it is a good stabilizing compound. With ultrasound contrast agents, it really comes in two different forms, which is it can either be in what's called the excipient, which means it's just floating around in the juice. It's not actually in the shell of the bubble. And that's the case for Sonaview or Lumason, or it can be in the shell, incorporated into the shell itself of the bubble, where it essentially produces a brush on the outside of the bubble. That's the case with the Definity preparations. There are other lipid agents that actually don't have PEG, things like Sonazoid, but they're not approved for use in the US. And so, so these things are kind of in there. But they're also in so many other things. And one of the big issues is, you know, we don't know, and it's a big unknown, how often somebody who has an allergy to a medication or to a cosmetic or to something else has an allergy to the active ingredient versus to PEG, right? So the only people who we absolutely know have allergies to PEG are people who have allergies to things that are only PEG, 100% PEG. And that's the bowel, some of the bowel preps used for colonoscopy or some laxatives. So that gives you a little bit of a backdrop of what kind of PEG is and where it is.
That's wonderful. Thanks, Jonathan, for that important insight. So Jennifer, would you like to keep going?
Sure, yep. So I guess in the reactions that we're talking about are in some ways anaphylactic, which are more serious immune-related reactions. Those are rare and attributed largely to pseudo-allergen reactions known to occur with the liposomal drug preparations. The potential for rare hypersensitivity reactions to PEG components recently was recognized after publication of case reports implicating this polyethylene glycol allergy. So PEG again is polyethylene glycol, also known as macrogol or polyoxyethylene. It is used in thousands, as Dr. Lindner just stated, enteral and parenteral drugs, common in cardiovascular medicine. And this allergy is rare, but it has been established in literature. Of the FDA approved ultrasound enhancing agents, only lipid-based agents, which is Definity, Lumison, Luminity, and Sonaview contain PEG or PEG-liated lipids. The incidence of anaphylactic reactions is again exceedingly rare, less than 1 in a million doses of the ultrasound enhancing agents administered. And for prevention, the package insert for these have been updated to specifically caution against their use in patients with hypersensitivity reactions to PEG. So the document is great in giving some recommendations for lab policies. And the good news is that there isn't a whole lot that changes. So we still know that the incidence is exceedingly rare. 1 in every 10,000 administrations, patients will have a reaction, and those are not the severe anaphylactic reactions. And they don't recommend any changes to lab policy with respect to the indication for the use. We all know that contrast is a great additive to a lot of cases. 20% of our patients have technically limited images. And then this, the second portion of this will talk about the actual benefits for heart failure admissions using contrast on the first echo. So recommendation number 2 is that these patients, these UEAs are contraindicated in patients who have a known or suspected hypersensitivity to the components of the UEA still, so that is unchanged. And I think, from a sonography perspective, we'll always ask patients, do you have, have you ever had a reaction with Definity to perflutrin? And most people look at you like, what are you talking about? Because it's not a very commonly used drug. I think it's used in like an eyeball surgery. So I think, we say it to patients, and the answer is always no. I think in, scanning for 20 years, I've had one patient recognize the word perflutrin, and they had some sort of either cataract surgery or something like that. They weren't allergic to it, but they recognized the word.
Most people can't even pronounce it, so that's amazing.
Right, exactly. And then, so the second part of the recommendation is when you're asking patients about that, to then also include this, do they have a known hypersensitivity to PEG? And I think, again, it's going to be, instead of eyeball surgery, it's going to say, have you had, colonoscopy or any sort of invasive GI procedure where they gave you the laxative or the polyethylene glycol prep. And that's something, I think you're again limiting your population, which is usually what people over the age of 50 that have routine colonoscopies. But again, it's something that they would remember, hopefully. So patients may be unaware of products that contain PEG. So healthcare providers should inquire about the hypersensitivity to agents that contain it. So macrogol and bowel preps, colonoscopy, and laxatives. The third recommendation is to, again, remind and reassure your patients that these severe reactions are exceedingly rare. And I know that some people will usually say they'll describe the reactions when they say it, which, I wonder sometimes if it's like a if you tell someone that they could experience back pain, are they more likely to say that they have back pain after? So maybe someone will do a prospective study on that as well. The fourth recommendation is that sonographers, nurses, and physicians who routinely administer UEAs should be trained in the recognition of those hypersensitivity reactions. And there is an ASE guideline. I can't remember the year, but if you just, look up the guidelines on the ASE website for the performance of contrast echo, it does give you kind of a breakdown of what those are. And I think most of us, the most common thing is that back or kidney pain. Some people, headaches or nausea. I think, when patients start feeling diaphoretic, or if they ever say that they have chest pain, shortness of breath, things like that, those are kind of on the more serious end. And that cardiopulmonary resuscitation.
And Jennifer, would you say that most sonographers are comfortable providing this information to their patients, or do you think ASE has enough resources in this regard, or is this something we should be helping sonographers with more at this point? What are your thoughts on that?
I think that they do. I think that I'm lucky in that I came from two very large academic medical centers. So my experience is going to be different than a sonographer, working in a physician's office who may have recently added an ultrasound enhancing agent to their workflow. I can definitely say that, my first 10 years scanning, it was administered by nurses only. And then at my new position, my manager, there's a lot of barriers to doing it that way, like needing having an order from a physician, having a nurse be available. So I think that it reduced the use of DEFINITY in our lab, or I think we used, what's the other one?
Sonya.
No, the one that's not listed on the FDA approved. I'm completely spacing out.
That's okay.
Anyway, so DEFINITY, and then there was the other kind of big one at the time, 20 years ago. So for, transitioning into that, my new manager was like, if you guys can do it, it makes it so much faster. You don't have to wait for someone else to be available. You can be self-sufficient. You are the person that's ultimately deciding whether it needs to be used anyway. So that was a little bit, for me, it was a worry because I always had a nurse. There was always this process involved and another person that came in to do it. And it was almost like it was something I shouldn't be doing. But then, it's well within the scope of a sonographer, within the scope of our practice to administer it. So for me, it was a little nerve-wracking at first, but 10 years later, I wouldn't think twice about it now. So again, my experience is a little bit different, but I think that there are resources available. And I think at the conference, it is the scientific sessions and things like that. There is enough talk and enough presentations kind of about it. And I think that with the black box warning that came out, 20 years ago or 15 years ago, I think that also brought more attention to it. And then hopefully people have followed up and, learned that it is and can be very beneficial to patients. So
that's great to hear. And you're probably thinking of Optison, maybe.
Yes, Optison. Thank you.
Okay.
Optison is the albumin-based agent. So, yep.
Yeah.
Yeah.
Yeah, I do have to say, in terms of the resources that you've got at your disposal, there's really three main things if you've got questions about optimal policies and what you should be doing and what is recommended. Number one, there's the ASE Ultrasound Enhancing Agent guidelines. If you're listening to this podcast and you're from Europe, there's also a European guideline as well. Number two, the ASE actually, it's about 7 or 8 years old, but we actually had a very specific sonographer-directed recommended policy document. I believe that the first one was actually Tom Porter was the first author. I was actually on the guideline document. The other one was, I think, led by either Tom or Sharon Mulvey. But there's a third document that has recently been posted up, and this is what is colloquially referred to as the contrast playbook. It's the recommended policies for ultrasound enhancing agents. This was put out by the ASE. I actually led that effort, and it's got all of the policies on monitoring and who administers and who makes the decision, all the things that a laboratory would want to essentially uptick the use of ultrasound contrast agents. And allow laboratories to go to their hospital or clinic policymakers to essentially say, this is what we consider to be best practices.
Yep. So the fifth recommendation is just to remind folks that the FDA alert does not contain any information that would justify changes in laboratory policies. So again, those three documents that Dr. Lindner just referenced would be great, especially for those, if you are working in a small hospital or doctor's office and you would like to use DEFINITY because you're frustrated by getting your reports back that say unable to determine EF or wall motion or technically limited studies, that those are things that you could research yourself and bring to either your medical director, or if it's a practice administrator, to kind of get the program rolling at your own institution. So I think that's the end of part one, and then we can segue into.
Yeah, that's wonderful, Jennifer. I think, the key takeaway point is that it's low risk, and having this document really helps, I think, sonographers and the community, because we now have it in writing, and it's something we can refer to and share and even discuss with policymakers and nurses and managers. So thank you, Dr. Lindner, for taking the lead on this important document and putting this together. And also thank you for making it nice and short, actually.
Yeah. So, well, I just want to finish up with just a couple of comments,
sure.
Which is number one, everything we do in echo or medicine is risk to benefit ratio. Mm-hmm. This does not change risk to benefit ratio. The prevalence of a severe reaction is still 1 in 10,000. All it does is it helps us understand the mechanism. So we've always known that there is a part of the innate immune response. These are these CARPA or complement mediated reactions. Now we know that there are also more classic adaptive immune response type 1 hypersensitivity reactions. Doesn't increase the frequency. It doesn't change the treatment because the treatments still remain the same. Remember, epi, everything else is kind of secondary. And then number three, it just allows us to essentially fine-tune things to ensure safety. And by safety, I mean, if you have an allergy to an ultrasound contrast agent, you don't use that contrast agent. But also, if you have a known allergy to PEG or to those laxatives or bowel preps, you don't use a lipid agent. You can use an albumin agent. Of course, if you have an allergy to albumin or blood products, you don't use the albumin agent, you use a lipid agent. So this just helps refine our practice and ensure safety and decrease already a rare type of an event to an even rarer type of an event.
That's wonderful. Thank you for that summary. And as Jennifer mentioned, it's a nice segue into the next paper we're going to talk about. Sort of a paper that's coming down the pipeline. As I mentioned, it's in press, but hasn't been assigned an issue yet. And there's a number of papers that are discussing contrast. I thought this one would be good. Dr. Lindner is just going to give us a brief taste of the paper so that you can look at it rather than going through it comprehensively. So Jonathan, why don't you take it away? Thank you.
Yeah, so I'm going to be really quick on this one. Oops, let me come down to the slide that I wanted. There we go. I'll be very brief on this. I'm not even sure how much time I've got, Amar, so you just interrupt me when you can. This was a paper that came from a very large hospital group in the Georgia area. It was led by Manny Bannon, who's been in the ultrasound enhancing field for many a decade. So a good friend of mine, haven't seen him in a while. Hello, Manny, if you're listening. This was really a pretty straightforward aim here. What they did was, this was a hospital system that said, hey, listen, we're going to enact a policy where we're going to give ultrasound contrast agents as policy to anybody who's admitted for heart failure. And they did that in over years. They actually escalated the percentage of patients who came in with heart failure that actually got it. It ranged anywhere from around 40 or 50% up to kind of the high 60% of patients getting it. So not everybody got the ultrasound contrast agent, mostly because some people refused, or there wasn't staff to give it, or some other reason why it wasn't given. So they had a very, this is a large practice. So they had literally thousands of patients over a couple of years. And here's their question. If you get ultrasound enhancing agents or contrast agents upfront on your first echo early in your hospitalization, does it decrease the likelihood of having another echo that isn't really called for? So they came up with this big algorithm to say, is it called for or not called for? You can argue with their criteria or not. It was pretty reasonable, I think. And so and that's essentially the design of the study. So I won't go into it any further. And it did come from Piedmont, which has a pretty sophisticated heart failure group, 5,000 patients. And by the way, they did enlist patients who had both HFpEF as well as HFrEF, so reduced EF and preserved EF. So let's take a look at the results. Look on the right side here of this slide. So this in blue shows you the contrast usage, which goes from 50 to 74%. Yes, probably nobody out there is using contrast in 50 to 75% of their patients who are getting echoes. That's because of their implemented policy that if you come in with heart failure, you're going to get contrast on your first echo, okay, unless there was a reason not to. And you can see that as contrast usage went up, the likelihood for having unjustified repeated echoes, so a second echo that they didn't deem to be really needed, went down. Now, in the table, what you see is the actual percentages, and you can see those numbers there in the graph as well. This is not exactly the scourge of humanity here. We're talking about somewhere around 1% of patients actually got a repeat echo during their hospitalization. And to be honest with you, if you look at their criteria for what qualifies as unjustified, actually, these numbers are really quite low because, if you had somebody who you suspected had functional mitral regurgitation or secondary pulmonary hypertension, and you think you actually changed that and wanted to look later on in the hospitalization, that actually would have been unjustified. So these are really quite low rates. And so I just wanted to let you know that they're doing a pretty good job on resource utilization at Piedmont in terms
That's
of,
much lower than I would have expected. They're basically getting a good baseline echo and taking it from there in terms of the treatment and not really using ongoing ultrasound to guide treatment. They're using their clinical judgment.
Yeah. Now remember, they called things justified if there was a major change in status, or if somebody got a procedure, if somebody got a pericardial tap, all of those things. So there, there's a lot of reasons for having a justified second echo, but this is really, really pretty good. Here is I'll just point one thing out here, and this is really pretty important to kind of understand the results, which is there was a difference between the contrast and non-contrast group that was really important, which is the percentage of patients who had preserved EF versus reduced EF. As you can see, 60% of those who got contrast had reduced EF. 60% who did not get contrast actually had preserved EF, HFpEF, okay? So there was a slight difference in the patient population, and you can imagine that maybe a repeat echo would be more warranted in one group or another, and we can certainly discuss that a little bit more. But the bottom line is listed in the table 3 up at the top here, which is you had about a five-fold lower unjustified repeat echo rate if you were part of the contrast upfront group, okay? So again, these are very small numbers, but these data essentially suggest that if you use contrast up front, you're less likely to actually have a second echo later in your hospitalization if you've been admitted for heart failure. If you look at table 4 here, you can see that, no matter what group you're in, you are more likely to have a repeat echo if you had suboptimal image quality at baseline, okay? So if you didn't have really good looking echoes to begin with, you were more likely to get a second echo that was unjustified. However, that rate again was five-fold lower if you received contrast up front. So that's really pretty much the meat of the matter. There are limitations. This is a retrospective study. One of the big things is there were some substantial differences in the patient populations between them. But it kind of suggests that if you got good information and it really gives you, hard data that you have a high confidence in, you're less likely to have a second echo. I do want to make a couple of comments, which is number one, this really points to not just the accuracy of incorporating contrast, but also that use of contrast or enhancing agents will not only increase accuracy, but will actually increase confidence, reader confidence.
Mm-hmm.
We make important decisions based on knowing what the EF is or having a high level of confidence of whether there are wall motion abnormalities or not, or what the EF is. And so it's not just about accuracy, it's having a high level of confidence in that diagnosis. So I'll go ahead and stop there.
That's a really great point. And I guess the other thing I would want to add is that you want to be confident in something that is accurate, right? So you don't want to have an incorrect result that you're confident in either. So the confidence has to go with the accuracy to prevent false positives as well. And so I think for me, the key